So slowly correct, no greater than 10 to 12 milliequivalents per day. Treat the underlying cause, alright, give them fluids if they're dehydrated, treat their heart failure, treat their liver failure, give them dialysis, their renal failure, etc. Alright, and then this is I don't know about the sodium change per liter. Alright, so when you're trying to decide how much sodium are you going to give back, how much in your fluids that you're giving, you take the concentration of sodium that you're infusing. So, example, for normal saline, it would be 154 milliequivalents per liter, minus the serum sodium divided by total body water plus 1. So, for example, if we're going to give normal saline to correct somebody's hyponatremia from dehydration, we say that the sodium concentration, alright, so normal saline 154, let's say their sodium right now is 120. And they're 80 kilograms, so their total body water is about 0.6 times 80, I don't know, 48, so 49. Alright, so we have 154 minus 120 over 49. This is 34 over 49 is going to be about, what, 0.68 or so? I'm just estimating here. Alright, so what this is saying is you're going to get a 0.68 rise in the person's sodium for every liter that you give them. Alright, so if you want to know how many liters you have to give them, clearly it's going to take a while, right? This is not very much, but that's good because you want to go slowly in most situations. Alright, so now I'm not sure why I spent time on this, because honestly this isn't terribly useful, because what you really do is you start them on fluids and then you recheck every couple hours, because you don't want to screw up. Everybody's physiology is different. Once you start correcting the hyponatremia, then your physiologic parameters are going to be different. You can't constantly redo this. So you just check you check the sodium every 1 to 2 hours after you start correcting. And your goal is 125 to 130. You don't want to just take them all the way back up to normal, because, as I mentioned, physiologic parameters change as you start to correct, and so ADH will actually go down as you begin to fix this. So as you begin to fix the underlying problem. Okay. Now, for severe hyponatremia, you can also use the Vaptans. These are drugs that inhibit the V2 receptor. These are expensive. I haven't seen them used very often, but nephrologists probably use them. So you can use 3% normal saline, so just watch out, because this is going to correct very rapidly. And then this is, I think, an old antibiotic, demeclocycline. I'm not sure if I'm saying it right, but this creates a nephrogenic diabetes insipidus. All right, so kind of counteracting the increased antidiuretic hormone effect. But usually you'll be fine just giving normal saline and treating the underlying cause. And again, that's same thing right here. Fluids isotonic, hypertonic if acute. That's pretty much the one exception, is that if your hyponatremia developed very, very rapidly and the patient is having lots of symptoms from those rapid fluid shifts, then you can correct it relatively rapidly. But for the most part, it's going to be chronic and you're going to be correcting it slowly. Alright, so that's all I've got for hyponatremia. I'm going to attach a case study. Oh, focus, come on. Alright, that's all I've got for hyponatremia. I'll attach a case study that I've written up on the patient we had in the hospital with a sodium level of 102. As you can probably guess, it was a multifactorial hyponatremia. She wasn't dead, and so it was relatively chronic. And so we did a number of things to help fix that, and it was an interesting case. So hope you learned something, hope you enjoyed this, and thanks for watching.